This is Morgan, and I was given the assignment of rheumatoid arthritis this week. So we'll talk about the case introduction. Okay, so ML is a 50-year-old white female who has been working in the front office of a medical clinic for the past 5 years. She has made an appointment to see her primary care provider because she's been feeling very tired for the past month and has also been suffering from stiffness, pain, and swelling in multiple joints. She states, "I ache all over and I have pain in different places all the time. One day it is in my right shoulder, the next day in my right wrist, and the following day in my left wrist. I'm stiff everywhere when I get up in the morning, or if I sit for any length of time. And I feel so tired, like I have a case of the flu that just won't go away." The patient is allergic to IV iron, dextran, from which she has developed shortness of breath. She rarely uses alcohol and does not smoke, and she is taking an over-the-counter calcium supplement, Synthroid or levothyroxine, and venlafaxine. There is no family history of rheumatoid arthritis that she knows of. Rheumatoid arthritis is a systemic autoimmune disease that's characterized by inflammatory arthritis and extra-articular involvement. It is a chronic inflammatory disorder caused in many cases by the interaction between genes and the environmental factors, including tobacco, that primarily involve synovial joints. It is typically starting in the small peripheral joints and usually symmetrically progresses to involve proximal joints if left untreated. Joint inflammation over time leads to the destruction of the joint with a loss of cartilage and bone erosions. RA with a symptom duration of fewer than 6 months is defined as early RA. But once the symptoms have been present for more than 6 months, it is defined as established RA. RA, if untreated, is a progressive disease with morbidity and increased mortality. This activity describes the evaluation and management of rheumatoid arthritis, and we will review the role of the interprofessional team in improving care for patients with this condition. Pathophysiology of rheumatoid arthritis. It involves a complex interaction of genetic predispositions and environmental triggers that leads to systemic autoimmune responses, primarily the targeting of synovial joints. This response results in chronic inflammation and the progressive destruction of cartilage and bone. The key stages of this disease progress is triggering and loss of tolerance. So in genetically susceptible individuals, especially those with the HLA-DRB1 or shared epitope gene, the environmental factors like cigarette smoking, periodontal disease, like bacteria causing periodontal disease, which is Porphyromonas gingivalis, or certain infections can trigger an immune response at mucosal sites, the lungs and the gums. A key process here is citrullination, which is a post-translational modification that converts the amino acid arginine into citrulline in self-proteins. These modified proteins are seen as foreign by the immune system, which leads to autoantibody production. The immune system generates autoantibodies against these citrullinated proteins, or these are called anti-citrullinated protein antibodies, or ACPAs, and other self-antigens like rheumatoid factor, or RF. These antibodies can be detected in the blood years before joint symptoms ever even begin. Synovial inflammation, or synovitis. The autoantibodies and immune cells migrate to the synovial joints. The immune system mistakenly attacks the synovium, or the joint lining, which causes it to become inflamed and swollen. Immune cells like T cells, B cells, macrophages, and dendritic cells infiltrate the synovial tissue. This leads to joint damage and destruction, so the inflamed and thickened synovium develops into a highly destructive tissue called pannus. This pannus invades and erodes the adjacent cartilage and subchondral bone. And the destruction is mediated by various inflammatory cytokines like tumor necrosis factor alpha, interleukin-1, interleukin-6, and matrix-degrading enzymes, or matrix metalloproteinases, or MMPs. which are produced by invading cells and activated fibroblast synoviocytes. The activation of osteoclasts, which are the cells responsible for bone resorption, plays a vital role in bone erosions as well. Key cellular and molecular things that happen in this disease process include immune cells, so the B cells, T cells, especially CD4, T cells, Th1 and Th17, macrophages, and fibroblasts all contribute to the inflammatory cascade and the process that occurs in this disease. Autoantibodies, so RF and ACPA are very prominent biomarkers that contribute to the inflammatory process. These form immune complexes and activate the complement system. Cytokines, these signaling molecules, so tumor necrosis factor alpha, interleukin 1, and interleukin 6, are central to driving and perpetuating the chronic inflammation and the systemic effects of the disease. The chronic inflammation and joint damage can also lead to extra-articular manifestations and comorbidities, which can affect organs like the heart, lungs, eyes, and blood vessels, and contribute to increasing morbidity and mortality. Clinical manifestations. The patient is pleasant and alert, but she appears to be very tired. She is in moderate acute distress from joint pain. Her vital signs overall looked pretty good. So her blood pressure is 125/80. Her pulse was 80, respiratory rate was 15. Her temp is a little elevated, which could just be inflammation, but it was 100.0 degrees Fahrenheit, and she's at a normal height and weight. Musculoskeletal was really the only thing in her review of systems that was pretty prominently off. So her extremities, there wasn't any clubbing or ankle edema, but in her hands there was swelling of the 3rd, 4th, and 5th joints. So indicative of the RA at this point. Pain in the 4th and 5th, so they're still like more distal as far as pain goes, but the swelling has started to creep proximally, and the pain will soon follow that. She has poor grip strength bilaterally, which is just the inflammation and the weakening of the joints at this point. Her wrists were fine as far as at this point. She had good range of motion. There was a fixed nodule at pressure points on the left side, but other than that, nothing crazy. She had good elbow range of motion. She did have pain in her shoulders and decreased range of motion bilaterally there. But hips were fine. Knees, in her knees there were significant edema and pain and decreased range of motion bilaterally. In her feet, however, there were no noticeable edema, and her range of motion was fine. Lab work showed ESR is mildly elevated, which would indicate inflammation. White blood cells are mildly elevated, which also could indicate inflammation. RF, or rheumatoid factor, was positive, which indicates that there are rheumatoid factor autoantibodies in the blood already. This is a key indicator for rheumatoid arthritis, but not necessarily a definite diagnosis on its own. So it can be present in other conditions and even in healthy people, but with all of the clinical manifestations in the picture presented in the case study, it's probably diagnostic at this point of RA. Synovial fluid analysis was taken from her left knee. So they aspirated fluid from the joint. 7.4 ml volume, so a pretty small amount overall, with cloudy yellow fluid. It was present for white blood cells, so about 14,000, primarily neutrophils, a little bit of glucose. The combination of a cloudy yellowy fluid and high white blood cell count suggests predominance of neutrophils, which suggests the inflammatory process in the joint, most consistent with RA, like an RA flare. So RA is, the common cause of inflammation, synovial fluid with these characteristics. Other diagnostic tests were conducted as well. She had a chest x-ray done that was not conclusive, a urinalysis done that was not conclusive, and she also had a hand x-ray done just because of the swelling and the pain, and it did show that there was soft tissue swelling and bone demineralization, but no erosions yet. The role of the APN, the advanced practice nurse, plays a crucial and multifaceted role in the care of patients with RA. They act as an integral part of interdisciplinary healthcare. Their expertise helps to improve patient incomes, enhance patient satisfaction, and expand upon specialized and individualized care. Key responsibilities of the APN in rheumatoid arthritis care include diagnostics and assessments. So we should conduct comprehensive health histories and physical exams with particular attention to joint pain, swelling, and stiffness in patients that complain of these things. They should order and interpret diagnostic tests like the RF, ACPA, ESR, and imaging studies like x-rays and MRIs, which will help diagnose RA and monitor disease progression. Treatment plan development and management in collaboration with rheumatologists and other specialists like physical therapists and occupational therapists. They should develop and implement and adjust comprehensive treatment plans, including medication management, so making sure that patients are staying on top of their pain medications and their anti-rheumatic drugs. And procedures, so if they need to have joint aspirations performed or steroid injections to alleviate pain and inflammation in specific joints, they should be doing that as well. Patient education and support. A primary role is educating patients and families about the chronic nature of RA, its prognosis, and some management strategies. Medication adherence is super important. Lifestyle modification, so a diet high in anti-inflammatory foods, exercise, low-impact activities like swimming or walking, and the use of assistive devices may help to maintain independence and function of the patient. Symptom management, so focusing on pain management techniques, including heat and cold therapy, balancing rest with activity, and then comorbidity screening and management. There are common comorbidities associated with RA and its treatments, like cardiovascular disease, osteoporosis, infections, and depression. APNs should coordinate care with primary care providers and other specialists to manage these conditions effectively. Patient advocacy and support. APNs should build strong relationships with patients and provide emotional and psychological support to help them cope with the challenges of living with a chronic illness. They also should act as patient advocates within the healthcare system and be there to connect them with community resources and support groups as needed. And then research and quality improvement. Many APNs are involved in research, program planning, and quality improvement initiatives that are aimed at optimizing RA care delivery and patient outcomes. So the integration of APNs into rheumatology will help ensure comprehensive, timely, and patient-centered care for individuals living with RA and managing the complexities of this disease across their lifespan. Some case questions. In terms of the progression of the disease, what do the results of the hand x-ray suggest? The results suggest that the RA is still relatively early and has not progressed to established RA, which causes erosion of the bone. But the swelling and the soft tissue enlargement can definitely indicate early RA. Question 2, which findings in the examination of the synovial fluid are consistent with the diagnosis of RA? So the synovial fluid analysis, as we talked about earlier, the combination of the cloudy yellow fluid, high white blood cell count, these are all evident of inflammatory processes in the joint and are most consistent with RA. And then identify 3 abnormal laboratory results. This says in table 80.1. You guys don't have that table, but I did include the labs in the clinical manifestations slide that are consistent with the diagnosis of rheumatoid arthritis. So the ESR, the white blood cell count, and the RF presence. The ESR and the white blood cells show that there's inflammation in the joints, and the RF positive result shows that the RA diagnosis is consistent with the findings, and the body has already produced the autoantibodies against RF. And that the other clinical manifestations and diagnostic criteria can help us diagnose that this is RA. Thank you for listening. These are my references that I used. Have a great week.